You know, sometimes you hear about diseases that sound like they belong, well, in a history book, right? Consigned to the past forever.
Hmm.
But the reality is some of them are still very much around, just sort of waiting for the right circumstances to reappear. Imagine a sore throat that's not just uncomfortable, but actually dangerous. You know, threatening to close off your airway and cause damage throughout your entire body.
Yeah, that's the reality of the disease that was, well, once a major killer, and which, as your notes really highlight, still poses a risk, especially, in a globally connected world like ours.
Exactly. And that's our mission today in this deep dive, to take your detailed revision notes on diphtheria and really pull out the absolute highest yield information.
Right.
We're going to unpack what it is, how it works, what it looks like, how we find and manage it, and crucially, what the potential outcomes are. Think of this as highlighting the core knowledge nuggets you need to solidify for your revision.
We're working directly from the material you provided, making sure we focus on what's most important and maybe even point out a few surprising facts that are easy to miss sometimes.
All right, let's jump straight in then. When we talk about diphtheria, what are we actually dealing with at its most basic level? Like, what is it?
Well, at its core, diphtheria is an acute infectious disease caused by a bacterium, Corynebacterium diphtheria.
Okay. And while it often starts in the throat, the notes make it pretty clear the problem doesn't just stay confined there.
Absolutely not.
Yeah.
It primarily targets the respiratory system, leading to local effects, sure, but the real danger comes from its ability to cause severe systemic illness, impacting, multiple organs.
This is a critical point from the material, isn't it? It's not just the presence of the bacteria itself, but specifically the toxin it produces that causes the severe disease.
That's spot on. Not all C. diphtheria strains produce this potent toxin. It's the toxin-producing ones that cause the full-blown, dangerous diphtheria we really worry about.
Right. So how does this bacterium, or rather the toxin-producing version, get around? How does it spread?
The primary route is respiratory droplets, think cough, sneezes, that sort of thing.
Mm-hmm.
But it can also spread through direct contact with an infected person or even, contaminated objects.
Okay. That brings us neatly to risk factors then. Who is most vulnerable? Looking at the notes, the biggest red flag seems kind of obvious. Vaccination status.
Precisely. The single biggest risk factor for severe respiratory diphtheria is being unvaccinated or not having completed the full immunization course. Vaccination is incredibly effective at preventing the severe disease.
But it's not the only thing, is it? The material points to environmental and social factors playing a role too.
Yes, that's right. Conditions like poor living standards, overcrowding, malnutrition, they can increase the risk of contracting the infection and potentially the severity if someone does get infected. The notes also link poor hygiene, particularly in some parts of the world, to cutaneous diphtheria, which is the skin form.
And adults aren't completely off the hook, even if they are vaccinated as kids.
Correct. Immunity can wane over time without booster doses, putting adults at risk of respiratory diphtheria. And here's a detail from the material that's, easy to overlook, but definitely high yield.
Oh, yeah.
Diphtheria can also be caused by C. ulcerans, which is sometimes carried by domestic pets like cats and dogs.
Wow. Okay. So when you're thinking through a potential case scenario for revision, you're looking for vaccination history, travel, maybe living situation, and potentially even pet exposure. That's
Yeah.
interesting.
Yeah, those extra details can definitely point you in the right direction sometimes.
Okay, let's dive into the how it causes such damage. The notes detail the pathophysiology, what's actually happening at a cellular level once that toxin gets involved.
Well, this toxin is pretty insidious, really. Its primary action is to damage the cells lining the respiratory tract. And this damage is what leads to the formation of that hallmark grayish-white membrane we'll talk more about.
But it doesn't just stay put on the surface, does it? It gets into the system.
Exactly. The toxin enters the bloodstream and circulates throughout the body. Its mechanism of harm is actually quite specific. It interferes with host L protein synthesis.
It's like a tiny saboteur that gets inside your cells and just stops them from building the proteins they need to function correctly. Is that a fair way to put it?
That's a pretty good analogy, yeah. It targets the cellular machinery, the ribosomes that build proteins, effectively, jamming the process. This widespread interference with protein production leads to tissue damage and dysfunction.
And the consequences, as the notes really highlight, particularly hit the heart and nerves quite hard.
Precisely. These tissues are highly dependent on constant protein turnover, making them especially vulnerable to the toxin's effects. This mechanism explains why we see those significant cardiac and neurological complications.
Okay, shifting gears slightly then, the epidemiology section focuses on the UK context. Why is diphtheria so rare here compared to, say, other places?
The number one reason, really, is high vaccination coverage within the resident population. The UK has been very successful with its routine childhood immunization program.
But the notes mention that we do still see cases, and often there's a link, right?
Yes, it's significantly more common in regions with lower vaccination rates and less developed healthcare systems globally. And the material points out that recent UK cases have often involved individuals arriving from these areas, such as parts of Southeast Asia, South America, Africa, and India.
So cases here are frequently imported, either by people moving from or maybe UK residents returning from travel to these regions.
That's the key epidemiological picture from the notes, yeah.
Yeah.
And this is super high yield for your revision, because questions often include a travel history component specifically to prompt you to consider conditions like diphtheria that are rare locally but, endemic elsewhere.
Good point.
And don't forget that C. ulcerans linked to pets. Again, that's another source route mentioned in the notes.
Okay, on to the clinical picture. What does diphtheria actually look like when someone has it? What are the key features coming through from the notes?
Well, initially, it can be pretty nonspecific. A sore throat, fever, maybe some swollen glands in the neck. You might just feel like a bad cold or pharyngitis at first.
But then there's the sign everyone kind of associates with diphtheria, the one that really stands out in the notes.
Absolutely. The characteristic grayish-white membrane that forms in the throat, covering the tonsils and pharynx. It's often described as quite tough and adherent, meaning it sticks on quite firmly.
And if that membrane gets large enough, that's where the immediate danger comes in, right? The acute threat.
Yes, leading directly to airway obstruction and severe respiratory distress. This is a life-threatening emergency. Beyond the throat, the notes list systemic signs like general weakness and malaise, just feeling really unwell.
And the toxin spread causes those severe manifestations you mentioned earlier, the myocarditis, neurological problems, organ failure.
Yes, exactly. The notes give specific high-yield presentations to look out for in clinical vignettes. Things like a recent travel history, especially to those lifted endemic regions, that classic diphtheric membrane, and pronounced swelling of the neck lymph nodes, described memorably as a bull neck.
Bull neck is definitely a visual cue that sticks in your mind.
It really is. The notes also highlight neurological symptoms, or neuritis, affecting cranial nerves.
Like difficulty swallowing due to paralysis of the palate muscles, which is mentioned as potentially an early sign.
Exactly. And the toxin's effects on the heart can cause things like heart block. The notes also differentiate between the non-toxin-producing strains, which might cause just, mild pharyngitis, and the toxin-producing ones, which typically have a more gradual onset, initially maybe resembling a standard upper respiratory tract infection before getting worse.
What about nasal diphtheria? The notes mention that too.
Yeah, that presents differently. Typically a watery nasal discharge that becomes thicker and often blood-stained, with a pseudomembrane usually forming in just one nostril. And the incubation period for diphtheria overall is usually somewhere between 2 to 10 days.
Okay, so for revision, when you think diphtheria and severe disease, maybe you could think of a sort of triad of major areas affected by the toxin: cardiac problems, myocarditis, heart block, neurological issues, paralysis, difficulty swallowing, and airway obstruction due to the membrane, potentially leading to that bull neck. CNA, cardiac, neuro, airway. How does that sound?
That's actually a really solid mnemonic.
Yeah.
Yeah, CNA helps recall the most serious complications in presentations. Though as the notes do mention, milder cases can just look like strep throat, and carriers might have no symptoms at all, which complicates things.
Right, and there's also the cutaneous form, the skin version. What does that look like?
The notes describe skin lesions starting as vesicles or pustules that break down into these sort of punched-out ulcers, often with a hemorrhagic base, so a bit bloody. They're commonly found on the limbs, like the lower legs, feet, or hands.
And that extensive list of toxin effects at the end of the section: cardiomyopathy, paralysis, respiratory failure, kidney issues like nephritis, thrombocytopenia, it really underscores just how dangerous this disease can be systemically.
It really does. It shows how far that toxin can travel and the sheer range of systemic damage it's capable of causing.
Okay. So given that variety of symptoms, some of which clearly overlap with other common things, how do we definitively diagnose diphtheria? That brings us to Differential diagnosis and investigations.
Yeah, this section is absolutely crucial because, like you said, early diphtheria can easily mimic other infections. The notes list common ones like strep throat, viral pharyngitis, and infectious mononucleosis as key differentials you need to consider.
So you need a high index of suspicion, especially if those risk factors like travel or incomplete vaccination are present, presumably.
Absolutely.
Yeah.
Symptoms alone are just not enough for a definitive diagnosis. You must confirm it with lab tests. Don't get caught out in a scenario just treating based on symptoms alone.
What other conditions are mentioned in the notes as potential mimics? Things to rule out.
Well, they include infections caused by related bacteria like C. ulcerans or C. pseudodiphtheriticum, peritonsillar abscess, oral thrush, epiglottitis, even herpes simplex or impetigo for the cutaneous form.
And there's that very specific detail about neurological symptoms potentially looking like Guillain-Barré syndrome, especially if you happen to perform a lumbar puncture. That seems like a very specific pitfall to remember from the notes.
It really does. It highlights the importance of keeping diphtheria in the differential diagnosis, even for what might seem like primarily neurological presentations, especially if the clinical context fits, travel, vaccination status, etc.
So how do we confirm it then? What's the gold standard investigation mention?
Okay, the gold standard is obtaining a culture, typically a throat swab culture. The notes specify using special media like tellurite agar or Loeffler's media, which helps see diphtheria grow.
But here's arguably the most critical diagnostic takeaway from the material, isn't it? The one you absolutely have to nail for revision. Culture alone isn't enough.
You're absolutely right, and this is key. A definitive diagnosis of diphtheria requires two things. You need a positive culture, A and D, a positive toxin assay.
Yeah.
You have to prove not just that the bacteria is there, but that it's actually producing the dangerous toxin.
Ah, okay.
And this specialized toxin testing is done in reference labs.
Got it. Culture plus toxin assay equals definitive diagnosis. That's the really high yield point from this section. What about routine blood tests? Do they help much?
The notes indicate they're usually pretty nonspecific. You might see a slightly raised white cell count or maybe some protein in the urine, but nothing that actually confirms diphtheria itself.
Okay. So, once we have that definitive diagnosis of toxin-producing diphtheria, how do we manage it? What are the key pillars of treatment outlined in the notes?
Right. The treatment essentially rests on three pillars: diphtheria antitoxin, antibiotics, and supportive care.
And timing is really critical for one of those, right?
Absolutely. The notes stress that diphtheria antitoxin is best given as early as possible for confirmed or even highly suspected cases. This is because it works by neutralizing the circulating toxin. It can't reverse damage that's already occurred to cells.
That makes sense.
Then antibiotics, like the intramuscular penicillin mentioned in the notes, are given to eliminate the bacteria itself and, importantly, stop any further toxin production.
And supportive care then addresses the complications like managing the airway if needed, dealing with heart problems, and so on.
Exactly that, providing necessary medical support for the specific issues the toxin is causing in that particular patient. The notes also emphasize isolating the infected person to prevent further spread, which is obviously crucial from a public health perspective.
And stepping back a bit, the ultimate management and prevention tool highlighted throughout the notes is routine vaccination.
Prevention is absolutely paramount. The notes detail that multiple vaccine doses and boosters are required according to standard schedules. Even fully immunized individuals might need reinforcing doses in certain situations, like outbreak scenarios or if they've been exposed. And immunization can also be administered during the convalescent stage after recovery.
Are there many reasons someone can't get the vaccine? Any major contraindications?
The notes mention very few contraindications, mostly related to severe previous allergic reactions to a vaccine component. It's generally considered a very safe vaccine, though rare adverse reactions like pain, swelling, fever, or very rarely things like seizures or anaphylaxis can occur, as listed in the material.
Okay. Finally, let's look at what happens after someone has had diphtheria, the prognosis and complications section.
Right. The notes really underscore that the outcome heavily depends on how quickly the diagnosis is made and treatment, particularly the antitoxin, is initiated. Early intervention dramatically improves the prognosis.
What's the overall mortality rate mentioned?
It's stated as being around 5 to 10% overall, with potentially higher rates in certain age groups, though those specifics aren't detailed in your notes. Still, a significant mortality rate.
Yeah. And the severe complications we're trying to avoid.
Well, airway obstruction is a major one, potentially requiring an emergency tracheostomy. Then there are the systemic toxin effects we've discussed.
Yeah.
Severe myocarditis, Neurological issues like neuritis and paralysis, respiratory failure, these can all unfortunately be fatal.
And long-term effects.
Yes, long-term effects on the heart and nerves are possible in survivors. Recovery, especially if there was myocarditis, can be quite slow.
But there's some relatively good news regarding the neurological complications, isn't there?
Yes, that's a good point. The notes do mention that most survivors actually recover fully from the neurological damage, including paralysis, although it can take time.
Let's just quickly list those specific complications called out in the notes again, just to kind of cement them. Paralysis, particularly of the palate and hyperpharynx muscles, is quite common apparently, affecting 10–20%, leading to that difficulty swallowing and nasal speech. Other cranial nerves can cause problems like blurry vision. More severe paralysis can involve the diaphragm, impacting breathing. Cardiac issues range from tachycardia and heart block right through to congestive heart failure, and of course that dangerous airway obstruction.
And thinking back to our CNA hook, cardiac neurological airway heed, those are indeed the areas the notes list as the major sites for complications. It holds up.
Hopefully this deep dive has helped you, the listener, cut through the detail in your notes and really see the absolute highest yield information on diphtheria, organized logically from, cause right through to outcome.
Yeah, framing the material this way, understanding the definition, the cause, who's at risk, how the toxin works, what to look for, how to confirm it, how to treat it, and what can go wrong. It's a really powerful way to structure your revision for pretty much any condition, not just diphtheria.
It turns those dense facts into a more memorable story, hopefully. Remember those key points. The toxin is key. You need culture and toxin assay for diagnosis. Give antitoxin early if you suspect it, and think CNA, cardiac, neuro, airway for the big complications.
And knowing the epidemiology like the traveling also really helps you spot potential cases, which, as we said, is a common exam technique.
So to leave you with a final thought based on everything we've covered today, how striking is it that a disease virtually eradicated in places like the UK, mainly thanks to routine vaccination, can still appear and cause such devastating widespread effects just due to imported cases? What does this single disease tell us about the interconnectedness of global health, maybe the fragility of public health gains, and the critical ongoing importance of maintaining high vaccination rates, not just locally, but actually worldwide? Something to think about.
It really puts the role of vaccination and maintaining that coverage into sharp perspective, doesn't it?
Absolutely. And as you continue your revision, remember, for more resources tailored specifically to your exams, do check out passthemsra.com.
And to test your knowledge with free practice questions on this and other topics, you can visit freemsra.com.
Thanks for joining us for this deep dive today, and thanks for sharing your notes with us. Keep that revision going strong.